Alright, today we're going to begin on the CPT chapter in your textbook, and we're going to start on page 264 and 265. Now, this is a lengthy chapter. It does have a lot of key terms in it, but we're going to skip a few sections. The main section, we're going to be skipping is the anesthesia section. So, let's get started on page 264. Now, I want to tell you before we start that CPT coding is very similar to ICD-9 coding. You're basically going to look up the code in the main index by the main term, and then you're going to check it in what we call the tabular in the ICD-9 book. However, it's not called the tabular in the CPT book. It's just volume 1, I believe. So it's very similar, but instead of diagnoses, we're looking at procedures, and this is where the bulk of the money comes from. But you know, also I know we talked about billing with the diagnostic coding. However, your procedure and diagnostic coding, you know, they have to correctly be linked together. So that's why it's important, especially for CPT codes, since they are directly linked to money. To be correct. So let's just look at the overview of the CPT. It's called the Current Procedural Terminology, and it's a list of descriptive terms that report medical services and procedures, and it basically gives everyone a universal language of a code and it relates to a fee. These codes usually, they do not have decimals. They're 5-digit codes like 1, 2, 3, 4, 5, and then occasionally they'll have a modifier. That's like a 2-digit modifier, and if that happens, you'll have like 1, 2, 3, 4, 5, and then a hyphen, and then a 2-digit code. But all of these are going to be 5-digit codes. The next chapter is the HCPCS, which is HCPCS. We just call it the HCPCS, and that is very similar, except we mainly use that for Medicare billing and some medications and things. And but anyway, that's kind of all a part of the CPT book. Okay, let's look on page 265. Let me see. I do want you to know in the middle of that page that new editions of the CPT book come out every January the 1st. That's when they're published. So you get a new book once a year, and it'll have revised codes, deleted codes, and et cetera, new procedures that may be done. So it comes out once a year on January the 1st. If outdated codes are submitted, I think it's like past 90 days, I believe, then the office is actually charged a fee. So if you're still using like the book from a year before and you use an outdated code, then you'll actually be assessed a charge. And then of course the doctor is going to blame it on you or whoever else the coder is. And then of course, more importantly, is that you're going to have delayed reimbursement. So CPT codes are used to report services and procedures that are performed on patients. So look at that bulleted list on page 265. We're going to use these to bill for, use these as services by providers in offices, clinics, and private homes. So, we got to charge like for an office visit, and we'll go into more about that. Office visits and consultations, those are all called E and M codes, or evaluation and management codes, but that'll be later on in the chapter. It's also used by providers in institutional settings like hospitals, nursing facilities, and hospice. It's used when the provider is employed by the healthcare facility. It's used by a hospital outpatient department, like outpatient surgery, ambulatory surgery. So those are the things that it's used with. So you will be using this on a daily basis. Alright, so we did talk, I think, in the first chapter about linking diagnoses and procedures. But on the claim form, and we'll look at this in class, but on the claim form, you do have a place where you have to put in the diagnosis, and then you have to link put in the procedure, and then you have to write the number of what diagnosis goes beside it, which one links And I believe when we did our first couple of case studies in the MOS software that you did this. So we did talk about this some, but we'll look at it more and more. And then that goes into medical necessity, which we've talked about several times. The procedure, you're not going to get money for the procedure unless there's a diagnosis that will show medical necessity, the reason for doing that procedure. So let's say if the doctor did a chest x-ray and you came in with, painful right ear, that's not linking up. And so more than likely the insurance company will not pay for that. Alright, looking on page 266, we're going to look at the changes to the CPT, and we're looking at the bulleted area in the middle of the page. We have 3 different categories of codes. Category 1 codes, Category 2 codes, and Category 3 codes. The Category 1 codes, these are procedures and services that are identified with a 5-digit code, of course, and then it gives you descriptions of it. So this is going to be shedding hair. This is going to be like your E&M codes, basically, which is where the chunk of the money comes from. This is where the physician will go to bill for that 1-hour new patient visit that you had with him or her. And so those are Category 1 codes. Category 2 codes contain performance measurements, tracking codes, and these are assigned for an alphanumeric identifier with a letter in the last field. We will more than likely not be using these yet. This kind of goes into the Hicks picks, and we're going to separate that in different chapters for now. And then Category 3 codes contain emerging technology. The only thing with this is something that is new, whether it's a new procedure or a new medication. If it's not been approved all the way by like the FDA or OSHA or whoever else has to approve it, then more than likely the insurance will not pay for it. It just depends on the insurance company. So going on down to CPT sections, the Category 1 codes have 6 subsections. You have the evaluation and management codes, and you do not have to remember the code ranges. This is just kind of there to help you out if you need to remember where they're located. So evaluation and management is where the patient comes into the office as a new patient, or the physician goes to the hospital to see the patient, or he goes to the nursing home to see the patient. So this is the visit between the physician and the patient. Anesthesia we're skipping over because more than likely, unless you work like an outpatient surgical clinic, you're not going to have to worry about anesthesia. Surgery, we'll talk about that, and that can be a little difficult. You have to be really careful with surgery. Pathology and laboratory, and then the medicine section. Okay, and I already told you, going down to the CPT number format, I already told you that these codes come in 5 numbers, so it's a 5-digit number. And these are usually standalone codes, meaning you don't have to have multiple codes. It's usually one code that identifies one procedure. But then, of course, you could have an indented code below it, and it may give you extra information on that. So when this happens, you want to use just the indented code. You don't want to use both of them. And if you look at that example on page 267, you have an example of a standalone code, which is arthrodesis of the ankle and the open. And then you have an indented code description, closed treatment of the proximal fibula or shaft fracture without manipulation, and then the indented code is with manipulation. So if it's with manipulation, it would only be 27781. You do not have to do 27780 and then a 27781. All you have to do is the tabbed in code. Now, if it's not with manipulation, then you would only use 27780. So I want to make that clear that when it is like that, you do not have to use both of those. You just use the one that relates to your diagnosis. Alright, going on to appendices. These are located between the medicine section and the index. And so if you look at that table, we have Appendix A through in. I can't remember myself. All of these we're not going to use, but you do need to know them for test purposes. Appendix A is a detailed description of each modifier. Now we will use that one pretty frequently, not all the time, but pretty frequently. So you may want to place a little marker there so you'll know that Appendix A is modifiers. And while you don't have to memorize any of these, but we'll get to modifiers in a little bit, but just so you know, you do not have to memorize every single modifier, but you do kind of need to know when to use a modifier, and so we'll get on that shortly. Appendix B is coding changes. We really won't be using that one. Appendix C is examples of E&M codes. It kind of shows you how to break it down, and it's mainly for the physician because the physician is the one that's responsible for assigning the E&M codes. However, you will have to look over what the physician's documentation, and it'll be your job to make sure that he does have the correct documentation to support that code. And we'll talk more about those in a little bit. Appendix D is add-on codes. You can mark this if you want to. However, add-on codes we'll get to in a second, but they're in the regular index and stuff as well. So, and they're identified by a little plus sign beside it. Okay, Appendix E is codes exempt from modifier 51. Flipping over, Appendix F is CPT codes exempt from modifier 63. Appendix G is a summary of CPT codes that include moderate sedation. Appendix H is alphabetic clinical topics that are located on the AMA or the AMA website. Appendix I is genetic testing code modifiers. Appendix J is actually, you know what, let's go through like Appendix G, and we're not even going to worry about H through N. So just remember A through G, those are your main ones, and I'm going to make a note that I told you that. So A through G are your main ones that we may use, and Appendix A is one that we're going to really use the most. Alright, let's go into CPT symbols. These are going to be just like the little symbols that you had in the tabular list, like the 5 with a circle around it, or shaded box, or you know, whatever. These are the same thing, okay, except they're in the CPT book. So the first one we have is a bullet. And a bullet is located to the left of a code number, and it just identifies as a new procedure. Now, do you have to do anything different? No, you don't, but you know, you may want to you can go ahead and write it down, but you may want to make sure insurance covers it since it is a newer code. If you have a triangle located to the left of a code, it identifies it's been revised. Do you have to do anything to it? No, but you do need to know what these little marks are for test purposes. Horizontal triangles, now they're not going to be together like this. They're going to separate. They're going to show the beginning of a note paragraph and the end of the note paragraph, okay? So, and it's kind of indented in the center of it. But these surround revised guidelines and notes. So, and you can see the example right there below it. The semicolon is used to save space in the CPT book, and some code descriptions are not printed in their entirety, and they're maybe printed underneath. So if you look at the example, scleral reinforcement with graft, you have 67250, scleral reinforcement, semicolon, without graft, and then 67225 is with graft. So obviously the code that we'd want there is the with graft, and all you have to write is 67255. Alright, then the plus sign is the add-on code, and that doesn't mean necessarily that you have to use two codes. It just means the add-on code, you cannot use just the add-on code by itself. Okay? Alright, so if you have something, I'll give you an example. If a person is getting like 50 skin tags removed, you may have something in the main area in volume 1 that says like for 30 skin tags you do this code, and then it's tabbed in, it has a plus sign, and it says for each additional 20 skin tags use this code. And so that means that you have to use the original code and then that code. So that's what that means. And remember, you can never report it by itself, and if it's got a plus sign in front of it. It has to be a secondary code. The bullseye identifies codes that are not to be used. I'm sorry, that's not a bullseye. We call that the Ghostbuster sign, or the forbidden symbol. There identifies codes that are not to be used with modifier 51. If you want to know what modifier 51 is, you can go back in Appendix A and look at the modifier description. Then flip on over to 270. We have the bullseye. This indicates a procedure that includes moderate sedation. So do you have to do anything? No, but it tells you that the sedation or the anesthesia part is included in it, and so you don't have to code it separately. Okay, moderate or conscious sedation, you do need to know this. That doesn't mean that they're put to sleep, but they're given a medicine to basically make them loopy. And it's administration of moderate sedation or analgesia, which results in a drug-induced depression of consciousness. So you're kind of awake, but you really just don't care. And so it's going to identify moderate consciousness sedation as a part of providing specific procedures. Okay. It is inappropriate for the physician to report a separate moderate sedation in addition to a procedure that includes moderate sedation. Okay. If the only exception is if you do that and then you have another procedure and the procedure has a bullseye beside it, and they do not receive moderate sedation, then basically you don't have to worry. Then that's the time where you can use an extra sedation. So, I'm going to try not to confuse you with all that. Okay, keep on going. The lightning flashed. The flash symbol or the lightning symbol indicates codes that classify procedures that are pending FDA approval. Now, I will tell you, with FDA approval, if they're pending, insurance may not cover. Okay, so you'll need to call insurance company and get like a confirmation of where they cover or if they do not cover. The hollow circle symbol indicates a reinstated or recycled CPT code. Again, you don't have to do anything with this. The number symbol precedes the CPT resequence code, which appears out of numerical order. And we may see those occasionally, but not too much. Okay, so we're going to look at all the different formatting of the CPT book. We're going to look at the guidelines. And if you look on page 271, this is kind of got it laid out for you. But guidelines are at the beginning of each section of the CPT book. And you need to make sure that you read over it before you start coding from that section, because it may have certain rules that may apply to certain codes. So you do need to make sure you look over it. And guidelines define terms and explain the assignment of codes for procedures and services located in a particular section. And if you flip over and look at Figure 7.2, that shows you an example of the surgery guidelines. Okay, and a lot of times they may not have anything to do with us, but then you just never know, so you need to look over them. Now let's flip back and look at Figure 7.1. This shows you the breakdown. You have the section, it's surgery, subsection, surgery in the integumentary system. The category is skin, etc., and it breaks it down a little bit more and kind of shows you some of the different signs that may be used. Alright, look at the bottom of page 271 and let's talk about services that may be unlisted, which is a very big possibility. An unlisted procedure or unlisted service is assigned when the provider performs a procedure for which there is no CPT code. Okay, and again, that does happen. So what you have to do with this is you have to submit a special report with the claim form. My mind went blank, sorry. and it's going to describe the nature of the condition, the extent of the condition, and the need for whatever procedure or whatever service you're providing. Okay, and then it will list pretty much everything about it. So it needs to be extremely detailed if it's an unlisted procedure or unlisted service. Okay, the notes section. If we have instructional notes, these clarify the assignment of certain codes, and so we have two different types. We have a blocked unindented note and an indented parenthetical note. Excuse me. A block unindented note is a subsection title and contains instructions that apply to all codes in the subsection. So look at figure 7.3 on page 272. The blocked unindented note. Basically, it's just a long term for a large section of notes, but it's unindented. And then you have the indented parenthetical note, and it's indented. And if you look back on figure 7.3, it is usually in parentheses, okay? And it gives you a little bit of extra information. Alright, so let's flip to page 273 and let's talk about descriptive qualifiers. These are just, that's just another term for the main terms in your book. These are terms that clarify the assignment of the CPT code, so they can occur in the middle of a main clause or after the semicolon and may or may not be enclosed in parentheses. So if you have an example there, destruction, let's see, pre-malignant lesion, and then you have the add-on code of 2nd through 14 lesions. So if you have 3 lesions, then you're going to use the first code and the second code. Okay, if you only have 1 lesion, you're only going to use that top code. Alright, so exercise 7.1 we'll talk about more in class, but these are just kind of reviewing your symbols and stuff. So let's flip on over to page 274 and talk about the index. If you look at figure 7.4, you can see an example of kind of what the index looks like. And it's alphabetical main terms, just like the ICD-9 is, and they're printed in boldface, and then it has like the little subterms below it. Single codes and code ranges. Besides, I know in the ICD-9 code you just had like only 1 code beside your diagnosis. But with this, with a procedure, sometimes you'll only have 1 code, or sometimes you'll have a range of codes. And so if you have a range of codes, you got to flip to the front of the book and look in that section and look through that range of codes to see which one is the best. So you have to do a little bit more reading with this type of coding. So if you look at the example there, it says repair, and then it says liver is tabbed in a little bit, repair the liver, and then all of the 3 things right there are tabbed in: abscess of the liver, cyst of the liver, wound of the liver. So those can be repairs basically. Abscess and cyst only have 1 code, but wound, you have 11 codes basically that you have to look through. And so if we're doing a repair of a wound on the liver, then I'm going to start at that first code and read all of them through 47361, and then pick out the one that goes with it most correctly. And you can see if you look at 7.4, the same thing with meningitis. Let's see, you have in meningitis, and then you have nails under that, and everything that goes with nails is underneath it. Some of them are single terms, some of them are a range of codes. So that's what the range of codes means. It means you have to look at the entire range. Now the cross-reference term is C, S-E-E. So if you see C, that means that you're going to go to whatever it says. If it says C, CAT scan, then you're going to go to CAT scan. So example there is AV shunt, and it may say C arteriovenous shunt. So it's giving you like the full term meaning. So that's what that means. Italicized type is used in the cross-reference, and it basically is when you see C in italics, that means that you need to go to that new term. And then inferred words, this is basically used to save space in the index, and so it'll give it to you in parentheses. Alright, let's flip on to page 276. For some reason I've got a blurry picture here. There we go. I don't know what happened. Alright, let's look at modifiers now. Modifiers are those 2-digit codes that go behind the 5-digit codes, and they're basically used for clarification. They're going to be used on procedures that happen, that's something out of the ordinary that doesn't usually happen. Like, let's say if somebody's having a mastectomy, and we do a mastectomy on both breasts, so we have a bilateral mastectomy. That's considered like a radical surgical procedure. And so there is actually a modifier for bilateral procedure. So anything that's going to be out of the, out of the ordinary, basically. If you see that example on page 276, a patient undergoes repair of a deviated nasal septum, which was unsuccessful. There's the thing that's going unusual. The patient undergoes a repeat repair, and et cetera, et cetera. So now we've got to look for a repeat surgical procedure. And that, so you can kind of see what I mean. I hope you kind of see what I mean by seeing things that, for the CPT modifiers that are unusual, that don't happen all the time. Alright, so let's look at table 7.1. Again, you do not have to memorize these, but you do need to be familiar with when you should use the modifier. So we have we have the first one, 24, is unrelated E&M code by the same physician during a post-op period. A significant separately identifiable E&M code by the same physician on the same day of a procedure. We have a decision for surgery. So let's say you go into let's say I go over to Medcare and see a physician, and because I think I've broken my leg, and they tell me I have to have surgery immediately, then they would give me like a decision for surgery modifier. Then we have increased procedural services. So let's say we had the patient coming in, just for follow-up, but she ended up talking to us longer and longer. We can use this modifier. Reduced services, kind of just the opposite. Discontinued procedure, discontinued outpatient hospital or surgical center procedure prior to anesthesia. So discontinued, again, does not mean that it's not done. It just means, that it's not done ever. It just means that for some reason surgery was canceled. Discontinued outpatient hospital procedure after anesthesia was administered. Flip on over, page 279. Surgical care only. We have something for post-op management only. We have something for pre-op management only. So you're hopefully you're seeing that these are things that are definitely not usually done. They're out of the ordinary. The next one is staged or related procedure by the same physician during the same period. Distinct procedural service. Altered surgical field. So, if the surgery took more time, or because, something happened, then we would use this code. Procedure performed on infants less than 4 kilograms. Unplanned return to the operating room by the same physician. Unrelated procedure or service by the same physician during the post-op period. A bilateral procedure. That's that example I gave you earlier about the mastectomy. Multiple outpatient E&M encounters on the same day. Let's see, flip on over. We have multiple procedures. So let's say we did a knee replacement and a heal to put in some kind of screws or plates in the foot for a fracture, we could use this for multiple procedures. A repeat procedure by the same physician, repeat procedure by a different physician, a surgery that requires 2 different surgeons, but the surgeons must be the same type. They can't be 2 different specialties. A surgical team, we have an assistant surgeon, a minimum assistant surgeon when a qualified resident is not available. And then we have preventative services. Preventative services is a new one, and we'll talk more about that later. We have professional component, so this may be like, well, you know what, we're going to skip the description of that because we're going to talk about the difference between professional component and technical component in the radiology section. Mandated services, so, if an attorney requires you to go have a drug test, we would do that as a modifier. Unusual anesthesia by a surgeon. Reference laboratory, repeated clinical diagnostic lab tests, alternative lab platform testing, and then multiple modifiers. So we do have quite a bit of modifiers here, and again, you do not have to memorize each one. This is just here to let you know, so you can kind of become familiar. But if you can remember, hey, I need to use a modifier when something out of the ordinary happens. Okay? Let's look on page 288. So we've talked about kind of the basic rules of coding and how we do it. So we're going to look at the steps. Alright, so we're going to read the intro to the coding manual, and you want to review the guidelines in front of each section when you do assign codes. Review the procedure or the service listed, and then what we're going to do is look in the CPT index and find the main term. And then main terms can be located by usually referring to the name of the procedure, but we can also, it could be the organ, it could be the condition documented, the substance being tested, so you have several possibilities there. Locate any subterms that go with it. Review the descriptions of each of those codes, and you'll have to flip to the front of the book to the proper section to do that. And then you're going to assign the code. Okay, so just like the ICD-9 code, sometimes I told you kind of have to use a play on words if your main term is not in there. Kind of the same thing with the CPT manual. So if you look at that little orange box, it tells you, like, if you looking for placement of a shunt and you go to placement in the CPT index and it's not there, you may want to go to insertion. Pacemaker implantation, you may want to say pacemaker insertion. Resection of a tumor, you may want to do excision of the tumor. So you have to kind of play around with your word use there. Okay, going on to page 290, we're going to start here talking about the evaluation and management section, and this takes up the majority of the chapter. It's a very large section, but we call this the E&M section. I'm not sure why this is blurry, but maybe it'll fix itself. Maybe I just need to say sitting back. But E&M section stands for Evaluation and Management, and it's used to code the service by the physician. And so this is where the big chunk of money is going to come from. So if you go in as a new patient and you talk, about 2 problems and you spend 30 minutes, then this is what the physician is going to choose for you. Now, a lot of times you'll see on super bills, and you'll hear the doctor say, will you give her a level 2 visit? And it's talking about the very last number. When he or she says that, they're talking about the very last number. Like you may have 99201 or whatever. So that would be considered a level 1 code. So I wanted you to make sure you understood that in case you hear something like that. So not only does this cover just the office, but they can, if the doctor goes and visits the patient in the hospital or at home, or, does a consultation, these are all considered E&M codes. Alright, so let's look at page 291. POS, make sure you know what POS stands for place of service. This refers to the actual physical location where the service was given to the patient at. Okay, so example 1, the provider treated the patient in her office, so the place of service is office. The E&M category would be office or other outpatient. Alright, the patient received care in the hospital's ED, so the place of service is the emergency department. The EM category would be emergency department services. Alright, so that's what the POS is and how you figure out the category. Then you also have to figure out the type of service. Are they a new patient? Are they established patient? Are you doing a subsequent hospital visit? Discharge visit? So what is it? So type of service refers to the kind of healthcare service that's provided to patients. Okay, so this is going to include consult, critical care, initial hospital, subsequent hospital care, etc., etc. So let's look at example 1. The patient underwent an annual physical exam in the provider's office. So the type of service is preventative care. In the E&M category is preventative medicine. Example 2, the hospital inpatient was transferred to the regular med-surg unit where he was recovering from surgery. He suddenly stopped breathing and required respiratory management by his physician. So obviously, anything like that would be considered critical care, and so the EM category would be critical care services. Alright, let's flip on over to break it on down further and talk about new and established patients and, concurrent care, all that good stuff. A new patient is someone that has never been in the office before or has not been seen in 3 or more years. An established patient is one that has been seen in at least 3 years, 3 years or less. Okay, so example 1, we have a Sally that's had a prescription renewed by Dr. Smith on January 1st of 2005, but she did not see the physician. She's been Dr. Smith's patient since her initial office visit in 2002. On December 1st, Dr. Smith treated Sally during an office visit, and that's in 2005. So she's a new patient in 2002 and an established patient in 2005. So I'm pretty sure you guys understand that. We've talked about new patient, established patients before. So let's keep going to page 293 and talk about concurrent care and talk about transfer of care. Okay, and you need to make sure you know all these terms. Concurrent care is the provision of similar services like hospital inpatient, etc., etc. And then transfer of care is when a physician who's managing the patient says, okay, we're going to turn over care to this person, or they refer them to another person. So that's what transfer of care means. Sorry, my nose is itching. Okay, let's look at E&M guidelines, bottom of page 293. These clarify that an unlisted service code is assigned when the provider furnishes an E&M service for which there's no CPT code. When an unlisted procedure does happen, you have to do that special report that we talked about, and we're going to just kind of skip on over that. If you look on page 294, this is the criteria for if you're providing an unlisted service, okay? You have to have that report, and it has to have that information on page 294 that's in bullets. You have to have the complexity of the symptoms, description of the service, diagnostic and therapeutic procedures, follow-up care, the patient's final diagnosis, and any other problems, the pertinent physical findings, and time, effort, and equipment that's used for the service. Okay, so those are all the things that you must have if you're going to list an unlisted service. Alright, let's talk about the different levels. And I already told you, and I think it may tell you in this section about, the level may say 99203, but the doctor may say, give him a level 3 code, and he's talking about that 5th digit right there. So you'll hear that a lot. Don't let that confuse you. So you got a couple examples there about different levels. So it says like 99201 classifies a level 1 office visit because it's 99201, so level 1 office visit. It's reported for new patients, and it includes problem-focused history, examination, and straightforward medical decision making. Okay, so those are the 3 components that we're about to talk about when you have to decide the E&M code. And let me just clarify that the physician is the one that decides this. However, you have to make sure he or she has the documentation to support it. Okay, and usually when the physician sees a patient, they can only do one E&M code. They cannot do multiple codes. Every once in a while, you may have something where you can have multiple codes, but usually just one code. Okay, so when we make this decision of what level we're going to be using, we got to look at the history that was taken on the patient, the type of exam that was done. Did we do, every body system? Did we only do the affected area? So, what did we cover? The medical decision making. I mean, did we automatically know what it was like that? Or did we, have to do a lot of testing and stuff and then decide? You have to do, think about counseling, coordination of care, the nature of the problem, and the time that's spent with the patient. So those are considered like your key components. And then you have contributing components as well. So let's look at the key components is the extent of history, the extent of the examination, and the complexity of the decision making. Okay. And then the extent of history. This goes into, you'll see these terms, a problem focus. That means, like if I just came in with a sore throat, the doctor's probably, going to run a strep test and, look at my throat, look at my vitals, feel my glands, and that's probably about it. So that's a problem focus, meaning we're talking about one problem. Expanded problem focus is, okay, if I came in and he checked my chest and everything around it, then that would be expanded problem focus. If he did a detailed history, then he's going to ask me a lot about my past family history, my current medical history, and then a comprehensive history is basically every body system, every type of family present history, etc., etc. And the same thing with examination. I think I got confused and did the problem focus with exam instead of history. But with examination, again, we'll use the sore throat. Problem focus would be just looking at the throat, the glands, things that are right around the throat. Expanded problem focused, a little bit more detailed. Then you have the detailed and comprehensive. Complexity of your medical decision making. You're going to have to look at that. You have to look at the number of diagnoses that were managed during the office visit. The doctor will look at the amount of data that they had to review, and they'll look at any kind of risk and complications that could happen or has happened to the patient before they decide, what decision is going to be made. So documentation to help support your whatever your level code is they're going to want to look at your labs, your x-rays, any kind of other extra documentation that you may have, any other physician's notes they may want to look at. And then the complexity of the decision making. We have straightforward, low complexity, moderate complexity, and high complexity. So straightforward, let's say I have a sore throat, I tested positive for strep, obviously my diagnosis is strep throat. Alright, so my diagnosis was straightforward, and then it gets, a little deeper each time. So again, we are going to look at all the terms so you'll know these, but you will not have to decide what to do. However, We are going to practice in class and do a few case studies, but it's mainly going to be used for you to become familiar with all these terms. All right, so let's look on page 301. Let's see. Okay, let's look at counseling. We're going to skip the contributory components for now. Let's go to counseling. Counseling refers to me sitting in your office and you're telling me about, infertility issues. You're talking to me about my diet. So it's face-to-face chatting. You're not examining me, okay? And you have to have 50% or more of your time counseling. So you cannot charge a counseling, you cannot use a counseling E&M code if you're not actually counseling in an office, okay? So make sure you remember that. Coordination of care, this is when, your physician may contact another physician to coordinate your care. Refer them because maybe you've got a stomach ache. He can't figure out what's going on, so he sends you to a gastroenterologist. So that's what coordination of care is. Okay, the nature of the presenting problem. This term means a disease, condition, illness, or injury, symptom, sign, finding, etc., with or without a diagnosis being established at the time of the encounter. So it's basically the chief complaint of the patient. So these are the 5 different types that are recognized. We have minimal, so the problem may not be very bad. We have self-limited, low severity, moderate severity, and high severity. And we'll talk more about those in class. Then face-to-face time. This is how long you spent with the patient. If you, let's say I did go in for strep throat, but I kept him in there longer talking about, some other kind of issue. He can actually go by time that he spent with me because, instead of 15 minutes, I maybe took 30 minutes of his time. So that's exactly what that is. And that's face-to-face time. Not counting how long they were waiting on the physician in the office, how long the physician actually came into your room until the time where he discharged you. Okay. So let's look at the E&M subsections at Table 7.2. We have the office and other outpatient services. This is your main area that you're going to be coding from because we're mainly coding only from the office. That's what this whole class is about. We will do some more, but we're mainly going to stick with the office. Then you have hospital observation. Then you have hospital inpatient. Then you have consults. You have emergency department services, and you may use those too quite frequently. Critical care services. You have nursing facility services, rest home or boarding home services, assisted living or home care oversight services, home services, prolonged services, case management services, care plan oversight, preventative medicine, non-face-to-face MD services, special evaluation services, newborn care, inpatient neonatal ICU, and pediatric ICU, other services. Yeah, and that's the last one. And we'll go into more detail on these. Again, I'm not going to make you remember all this information in each one, but this is just to kind of help you know that these are the sections that you'll look in. And the main one we will use is the medical office. Okay, the next section in your text is the anesthesia section, so we're going to skip that. And we're going to pick up with the surgery section. So we're going to start again on page 313. Alright. The surgery section has all kind of little subcategories, and they include like an incision section, an excision, removal, introduction, grafts, destruction, etc., etc. So when you see these, you can, if you can't find the surgery and the index, you can go into the main part of the book and look in the surgery section and then look under repairs and then try to find it by, site from that. Okay, sorry for the little interruption. We are in the surgery section. So anyway, to code surgeries, basically you have to have 3 little steps. You want to look and see what body system we're covering. You want to look and see what anatomical site we're looking at, and then what type of procedure was performed. So you have an example like excision of a lesion on the arm, on the right arm. And so what body system? Well, if we're doing an excision on the arm, that would actually be the skin, right? So we're in the integumentary system, so we go to that section. Then what anatomic site was involved? Well, it was the arms, or they may list it as extremities. And then what type of procedure? It was an excision. So those are the 3 questions you have to ask. Now flip on to 314 and let's look at the surgical package, or global surgery. And we've talked about this several times before, mainly in the first chapter. But this is when surgery, if you're coding like, let's say, an appendectomy or a hysterectomy, the coding, like a global surgery code, is one that includes everything: the pre-op, the post-op, the anesthesia, the surgeon's the actual surgery, like the sutures, let's see, immediate post-op care, post-op follow-up care, etc., etc., and it shows you on page 314 what it includes. So when that happens, you cannot list anything separately. It just has to be your appendectomy code, and you should know that everything is included in that. So a lot of times physicians will get in trouble because they'll want to unbundle the code and code everything separately when it's all inclusive. Okay, so let's see, let's look at page 315. Talks to you about unbundling, and I just talked about that too, and we've discussed it before. So that would be, instead of me, if I was doing something incorrectly in unbundling, I would code an appendectomy, and then I'd code the anesthesia for it, the E&M service for the pre-op and the post-op, the follow-up visit. So yeah, I would be doing a major no-no with that. So you have to be extremely careful. Let's see. Let's look at page 316 and talk about separate procedures. The parenthetical note separate procedure follows a code description that identifies procedures that are an integral part of another procedure. Okay, so in addition, a separate procedure code is reported if the procedure is performed independently of the comprehensive procedure, or it's totally unrelated. Otherwise, if it's a separate procedure, you cannot use it. So it gives you an example. Cysto-urethropy, that would be a separate procedure in parentheticals, or parentheses right there. And then, so if you're doing that as a extra one from, like a similar surgery, then you could use that. But if you're doing something that's included, that this surgery is included with, then you would not be able to use that one that says separate procedure. You'd have to use one of those ones below it, like cysto-urethropy with ureteral catheterization, things like that. Multiple surgical procedures is basically pretty self-explanatory. It's when more than one surgery is performed. You have multiple surgical procedures. Where it says 2 or more, sorry, I said 1 or more, but it's actually 2 or more surgeries are performed during the same operative period. Okay, now let's go to radiology on page 318. Radiology is where you're going to go to code like your CAT scans, MRIs, chest x-rays, IVPs, things of that nature. Now, with this, we have different subsections of the radiology section when we're looking in the main area. And remember, you can go to the index and look up, X-ray under X's and get a series of codes, but then you have to go to the main part and look at all the series of codes and figure out the best one. So that's why we got to look at all these little subsections on table 7.3. Diagnostic radiology. This is going to be like your complete X-ray of facial bones or complete chest X-ray, CAT scan of the cervical spine. So all of that doesn't include any kind of extra component with it. Then we have diagnostic ultrasound, pretty self-explanatory. Radiologic guidance. This is like maybe if you're, let's say, doing a balloon angioplasty, but then someone's in there, and they're doing like a radiograph so you can see where you're going. That's where you would go for that. Breast mammography, bone or joint studies like a DEXA scan. Radiation oncology, like if somebody's having a radiation treatment for cancer, that's where you would go. Nuclear medicine, this is where anything with contrast is going to be taking place. You would go to nuclear medicine, like a Muga scan, IVP, things of that nature. Now, when radiology uses a complete procedure, that means that basically multiple views were used to complete the procedure. Let's see. Let's flip on over and talk about on 320. Let's talk about the difference between a professional component and a technical component. And make sure you remember this, not only for test purposes, but when you're coding as well, because you can really mess something up, especially if you actually are interpreting the x-rays or the radiographs in your office and you report, technical component only. That will, take away a lot of money from the physician. So the professional component is basically when you're in an office, they take the x-ray, but they send it off somewhere else for it to be read. Okay, so you're only doing the professional component. And then the technical component is the person that's actually, I'm sorry, my bad, I got it all backwards. The professional component is where the radiologist actually reads the x-ray and makes a report. And then the technical component is where the medical assistant or rad tech or whoever is the one that's actually performing the x-ray. Okay, so that's the difference. So most commonly you may have places, at office, we can do a few little x-rays in the office, so we're doing the technical component, but then we may send it off to a hospital to have the professional component done. Alright, so make sure you remember that. And then let's look at bottom page 321, path and laboratory section. So this is going to be subcategorized by whatever procedure is being done. And then the procedures are listed alphabetically. So all these little subsections are going to be within the lab section. You have disease-oriented panels like a cholesterol panel, a metabolic panel. We have that section, a drug testing section, therapeutic drug assay section. This is where, like, if I'm taking, let's say, a medicine for seizures, and the physician wants to see how much of that medicine is built up in my system, that's a therapeutic drug x-ray. Evocative and suppression testing. This is like positive or negative tests, like strep, mono, pregnancy. Consultation, pathology, urinalysis, and chemistry, hematology, immunology, transfusion medicine. Then we have microbiology, anatomic pathology, let's see, surgical path, etc., etc. So those are all your subsections. And again, you do not have to memorize these by any means. This book is just trying to lay it out so you'll know what you're looking at when you do look at it. And if it seems confusing now when we get in class, we'll flip to the area, or you can do that now, flip to the area that we're talking about and look through. Actually, you don't have a CPT book yet, so you'll have to wait till we get the CPT book. But I'm pretty sure that you will understand once we get the CPT book. The medicine section, you have non-invasive procedures, and then you have invasive procedures or moderately invasive procedures. So non-invasive means that we're not entering any cavity or skin. Minimally invasive means, like we may be doing an IV or something like that, but we're not cutting the patient open. And then all the subsections in that is you have immunoglobulins, you have vaccines, psychiatry, biofeedback, dialysis, gastroenterology, ophthalmology, special, basically ENT services, cardio, non-invasive vascular, pulmonary, allergy and clinical, immunology, endocrinology, and I'm not going to name all of them, but those are all your subsections that are in the medicine section of the CPT book. And then we're going to skip over the National Correct Coding Initiative. And that is actually it for this chapter. So again, if you're confused, a lot of this chapter is telling you all these different subsections in each larger section of the CPT manual. And again, I want to remind you, so you're not freaking out, that you do not have to memorize these sections, but it's showing you what these sections are. So when you look in your coding manual, you will know where it is. Now, I may ask you questions like, if I'm going to, if I need to code an excision of the right thigh, where would I go? Well, I'd go in the surgery section, and then maybe the integumentary subsection. So I may ask you questions like that. So we'll stop right there, and we'll try to recap a little bit as we're coding and do some examples so it makes more sense to you.